Hi everybody, Lisa here with IVF Manifesting a Miracle, and I'm doing a clinical conversation today with our friend, Dr. Greene. Hi, Dr. Greene.
How you doing there, Lisa?
I'm good. So good to see you. We haven't done one of these in a little while, and this topic has been a pretty hot topic that I see out and about, and I get questions about this myself related to PGS testing, pre-implantation genetic screening test.
Well, and to make things even crazier, they changed all the acronyms. So, it used to be called PGS or CCS, complete chromosomal screening. Now, the current terminology is PGT with a -A.
Oh my goodness, I can't keep up.
And, well, and then the point of that is it's pre-implantation genetic testing. And then the A stands for aneuploidy.
Okay.
And the point is, this is looking for just random genetic abnormalities that can happen in the normal, sperm-egg interaction of any healthy individual, meaning not looking for a specific metabolic disease, which is PGT-M.
Oh my goodness. Well, you're the expert, and that's why I'm asking you these questions. And there's been a lot of talk, people wondering, should I do this test? Should I not? I myself am a big fan of the test, and our whole story, just ruling out any chance of not having healthy embryos with matching chromosomes and ruling out potential risks of miscarriage and things like that. I would love to hear your thoughts on, from your perspective, as well as maybe your clinic. I don't know if you do what you recommend to all of your clients, if it's a common thing, but I just kind of love to hear your thoughts.
Yeah, well, first of all, just from again, a bit of personal perspective, having been in this field for 25 years, and also having been a patient at one point in the process with my own wife, it still boggles my mind that 30 to 40% of patients are still treated under a diagnosis of unexplained infertility. Okay.
Mm-hmm.
Now, I'm a very strong advocate of genetic testing and PGT-A, again, using the current terminology. And the point is most of our patients, and over 90%, probably over 95%, choose to do the genetic testing. And the reason I think that I'm such a strong advocate is the way we do things. It's been very effective that the vast majority of our patients have a successful pregnancy. Of the people that don't, they come away with a lot more useful data on why they weren't getting pregnant. And that information can be critical in determining, should I do another cycle? If so, what should I do differently to try to boost the outcome? And so to me, I view my primary goal to the patient is to create a healthy, successful live birth. And my secondary goal is to create additional embryos for future use if they think they want to have siblings. But my tertiary goal is, if I don't achieve one or two, is to answer, why are they not getting pregnant and what do we need to do differently?
Right.
And I could tell you, the idea of just doing repetitive cycles and hoping for a better outcome does not serve most people. But it serves the fertility centers very well. I mean, as a fertility center, we make more money if people just do repetitive cycles, but that's not the ethically appropriate thing to do. We should be creating a goal. Primary goal, live birth. Secondary goal, what can we learn if we're not successful in our primary goal? Because more often than not, we find that the reason people aren't getting pregnant is because of issues related to egg quality or sperm quality, and you can't diagnose that without doing genetic testing of the embryos.
We'll have to do a whole nother talk on egg quality, but with the when the test is done, just to give people an idea, because I didn't really know much about it when I was going through our process, but I wanted to rule out any things that would potentially inhibit, this working out. So I wanted to give ourselves the best chance. And so what happens is there's a laser that goes in and they take a little part of the cells, the outer layer of the cells. Is that right?
Yeah, first, as we talked about previously, we selectively insert one perfect looking sperm into each egg to minimize the chance that a bad sperm is going to ruin a good egg. Even when we do that, not every egg will fertilize,
Right.
okay?
Mm-hmm.
And not every egg that fertilizes grows. And this does give us some insight into egg quality.
Okay.
But for every egg that makes the blastocyst stage, which is the stage where they normally arrive into a woman's uterus, that we're able to tell by looking at the embryos, get a rough idea of what the embryo quality is, an estimation just based upon their appearance.
Okay.
But what we're showing here is this is actually a glass needle removing 1 to 2 cells from the portion of the embryo that would be destined to become the placenta, okay?
Mm-hmm.
Now, that tissue should be genetically identical to the remaining portion of the embryo. And so we're able to remove 1 or 2 cells from what would become the placenta, but not damage that cluster of cells in the interior portion of the embryo, what's called the inner cell mass.
Okay.
Because that cluster of cells is what becomes the baby.
Yeah.
So you want to make sure that you're staying away from those critical cells and just removing 1 or 2 cells from what would become the placenta. Then the embryo has to be frozen.
Mm-hmm.
And again, this is part of the process, and you have to have a very efficient way of freezing embryos without damaging them in order to do the genetic testing.
Gosh, it's such a complex procedure, intricate just procedure to.
Yeah, and just to give you an idea of the size of a human embryo at that stage of development is generally about 0.2 millimeters. So a little bit smaller than a period on a typed page.
Oh my gosh.
Okay, so
Yeah.
it's a very, it's a procedure that has to be done with great caution and also with great skill. And that's why you only want people doing this that are very well trained in doing this. You don't want someone that does this once or twice a month. You want someone that's doing this several times a day, so you know that they're very good at it, that they're not going to damage an embryo. Like someone often will say, doesn't it damage the embryos? And it's like, absolutely, if you're not very good at it, Yeah. But I always tell people what's considered a simple surgery like an appendectomy could be very dangerous if it's a surgeon that doesn't know how to do it.
Completely. Is there a certain age that you recommend doing this test, or is it really based on individual?
Again, I think it's really critical that people should have an idea of just a basic understanding of what we are understanding today about human biology. This is a diagram I was trying to show you earlier before we connected.
Mm-hmm.
And this line in red, are you able to see that okay?
Yep, just maybe show the sidebar a little bit. There you go. Okay.
That red line is the given chance that any egg is a healthy egg even before it meets up with a sperm. And you could see that the shape of that line is an inverted U.
Yeah.
And the point of that is women that are less than 20 are more likely to have abnormal eggs than women that are between 20 and 27.
Less than 20 abnormal eggs?
Exactly. In other words, the reason it's an inverted U is that younger women are more likely to have normal eggs than women in their mid-20s. And, and then as women get older, then you get a higher risk of abnormal eggs for a different reason, but with the same result. And this is why we see, if you look at that black line, despite our fears of teen pregnancy, you could see that peak human fertility is between 25 and 30 years of age.
Okay.
So younger people may have more frequent sexual encounters, but they actually have less chance of getting successfully pregnant each time they do get, have a sexual encounter, and they're more likely to have miscarriages. And the reason that they're more likely to have miscarriages is due to abnormal embryos. So the point is that everybody thinks that, that everything should be very simple. But the more we learn, the more complicated it is that we learn, because even for women at their peak fertility in human species, you know, the given chance that any egg is abnormal is about 60 to 70%.
Wow.
Okay.
That's high.
And the point of that, I'm sorry, I misspoke. The chance that any given egg is normal is 70%.
Oh, that
So
it's
even for the most fertile woman, has about a 1 in 3 chance that an egg is going to be abnormal. Okay. And that's for a very fertile person. Now, the reason that this is so difficult for people to, you know, appreciate is when you look at other species, for instance, like other primates, our closest genetic relatives, 95% or more of their eggs are genetically normal. And that's why they go into a heat cycle and they have a very high pregnant rate and a very low miscarriage rate. If you look at animals in the rodent class, like rabbits or rats, their eggs are 99% of them are genetically healthy. And that's why they have such a high fertility rate.
Yeah.
But in humans, even at your peak fertility, the given chance that any good egg is normal is about 70%.
Okay. That it's
Now,
normal.
when you consider the fact that even in the most fertile guy, about 1 out of every 10 sperm is a normal sperm, you know, if that good egg meets up with an abnormal sperm, it's game over.
Yeah, right. Can you
At
share?
least for that month.
Yeah. Can you explain transferring untested embryos? And I know you can do that at your clinic, but if you know that there is some type of abnormality, you do not transfer those embryos.
Yeah. Yeah, you know, believe it or not, not all medical schools have their graduates swear the Hippocratic Oath. But at my school, we did, and I take it very seriously. Part of the Hippocratic Oath is that we are not supposed to do any harm.
Right.
And so, as a physician, to knowingly know that an embryo is abnormal and then put it in embryo is doing harm. I'll give you an example. It's comparable. Imagine if I were a transplant surgeon and I have a kidney that I could put into someone, but I look at the kidney, I say, it looks like this kidney has cancer. I'm going to put it in anyway. You could see how ethically inappropriate that would be.
Right.
Because you might be curing the person's renal disease so they don't need dialysis, but giving them cancer instead.
Yeah.
Okay? And so we can't knowingly do something that we know has harm. And, you know, putting in an abnormal embryo is potentially creating harm to the woman because every pregnancy has the potential risk of bad things happening. And we've discussed that before. Okay, so it could harm the woman, but even if it doesn't harm the woman, it can have an adverse effect and a lifelong adverse effect on the child that results. And so we can't knowingly say, hey, this embryo is abnormal, let's put it in anyway. That just doesn't make sense. Now, you know, if people, you know, feel that they could not dispose of an abnormal embryo, then we just agree, let's not test. And if we don't test, then I could put in an embryo and we could just all hope for the best.
How often do you do that? How often do you transfer untested embryos? Is that common, or do most people prefer?
It's less than 5%. Most of our patients come to us because they want a healthy live birth. Right. And if they don't get a live birth, they want to know why they're not getting pregnant. And that's what the genetic testing can solve, is either create a live birth or it can explain why you're not getting pregnant.
Thanks for sharing that. And do you have any research to share on embryos that are an aneuploid, which means there's an abnormal number of chromosomes, like too many or too few? Can those reverse themselves in?
No. There's no evidence. Pardon?
I've been hearing just a lot about that, like women who research, I don't know what's out there exactly from your standpoint, like,
yeah.
Can it
and the point is, it can't reverse itself.
Oh, interesting.
No, and the point is, if you do a bad biopsy, you know, or your technique isn't good, people are used to hearing false positives and false negatives. Okay, now that we're talking about COVID-19, okay?
Yeah.
And if you're not using a very precise tool, you know, if you say that you're using a tool that has, you know, 80% accuracy, that means, you know, that 20% of the time that you say that something is abnormal, it really isn't, you know?
Right.
And so that's why you have to understand the precision of the tools that you're working with. We typically are transferring embryos that have an over 95% accuracy in their call, and oftentimes it's over 99%, okay? And whenever it's lower than that, we say, you know, because we know for each individual chromosome, it's 99% for this one, 99% for this one, 99% for that one. Maybe this one it's 95%. And we explain to people that there is a certain degree of uncertainty. But that doesn't mean that it reversed itself. That just meant that someone didn't convey the accuracy of the test results at the time of the transfer.
Okay. And what I also hope people get from this is what you're saving, not just, you know, emotionally with possibly avoiding different miscarriages or those kind of heartbreaks, but also financially saving yourself a lot of money from doing multiple transfers. You and I chatted.
Well, and this is part of what I think is so ethically challenging, because as a fertility center, we're paid to do transfers. And so when centers are encouraging people to transfer untested embryos, they're basically feeding their own income.
Yeah.
Okay. Now, the reality is, you know, if it costs somebody $2,000 to test 8 embryos, and I'm just pulling out some approximate numbers,
Yeah.
you know, and it tells you that maybe 3 of those 8 embryos are healthy embryos, you could go through 3 or 4 transfers at anywhere from $5,000 to $8,000 a transfer to find one of those good ones, you know. Now, it's possible you could get lucky and get one of the good embryos right off the bat,
You're
but
rolling
not
the
everybody
dice.
is lucky. And,
Yeah.
and the reality is most people aren't lucky. And so as a center, it's more financially lucrative to transfer untested embryos.
Mm-hmm.
Because again, you know, at least not every center is set up the same way. We send out the genetic testing. So that money is not going to us, it's going to the company that's doing the testing. But if you don't have a healthy embryo, I'd rather you don't pay me for a transfer.
Yeah.
Than to pay me for a transfer for an embryo that either is not going to implant or is going to implant and cause a miscarriage.
Yeah, no, I'm so grateful that we did the testing, and like we chatted just before the call, you know, our first 4 not healthy embryos. If I had transferred one of those 4, you know, multiple.
Or imagine if you had done all 4 of those, that probably would have been anywhere from 1 to 3 transfers, depending on if you got desperate and started putting in 2 at a time.
Mm-hmm.
And think of how much each one of those transfers would have cost you.
Oh my gosh. Yeah. And just
Emotionally, as well as
yeah,
financially, as well as time-wise.
And then that second egg retrieval, getting 3 embryos, and only one of ours was healthy, and that's our daughter. And so just you
So
reassure.
a classic example, 1 out of 7 tested.
Yeah, 1 out of 7 tested. So, I mean, my heart goes out to those women who've had multiple failed cycles and miscarriages. And I just think like this can be one step to help you get closer to your goal of having a baby, just to know ahead of time, is it a healthy embryo?
And, you know, one of the other things that's important to mention, and we've talked a little bit about this previously,
Mm-hmm.
the 2 of us have,
Mm-hmm.
that depends on the testing method that you use. But with some of the testing methods, and the one we most commonly use, which is a technique called SNP array technology, it uses the same sort of testing that's used in criminal courts. So with each embryo that we're testing, when we use that technique, it's not only telling us whether the embryo is normal or abnormal, but when it's abnormal, it tells us whether the abnormality came from the egg or the sperm.
Yeah.
And that could be critical as well, because if you're picking the best of the best sperm and you're getting embryos that are abnormal because of the sperm, that could be critical information that you need to know.
Yeah.
And you might otherwise assume it's an egg quality problem when maybe it's actually the sperm.
And I wish I had that clarity when we were going through our steps, but like where it's sent out, certain places you were explaining to me, there's multiple places that do these tests. And so you kind of sit down with your patient and decide, I think we need to determine.
Yeah, because the testing method that I mentioned is more expensive than some others,
Okay.
but it's also more informative.
Okay.
And some people say, well, you know what? I'd rather have some information, and I'm willing to sacrifice some information for expense.
Okay.
And that's okay. That should be their choice.
Yeah.
But it shouldn't be someone else choosing for them, whether it's me or anybody else.
And cost wise, you're not really sure on that, like what it could go up to.
Well, the big difference is that, for instance, to do the snip array technology, the genetic testing company has to create a specific profile for the woman and her male partner. And there's a certain amount of expense for that. And so they charge a flat fee for up to 8 embryos. And then if someone has more than 8 to test, they charge per embryo beyond that. Now, for the other testing methods, they don't have to set up that format. So what they've started doing is many of them charge per embryo. So if someone is only going to produce 2 embryos or 3 embryos, it'll be cheaper to go with the other testing method, but you won't be able to have the sourcing information.
Okay. And they would do the panels, those individual panels for same-sex couples, male, female. They look at everything, correct?
Well, when we're dealing with a single woman or a same-sex couple, we have to send a sample from the donor sperm for comparison. Okay. That's why I said the male partner and the female, because it's not necessarily a partner.
Right.
Sometimes it's a male donor.
Right, and donor embryos too, so.
But we even recommend, genetic testing when people are using an egg donor. Because again, even the best egg donor, at least 1 out of every 3, embryos is going to be abnormal. And sometimes it's as high as 50 or 60%.
Wow.
And again, what could be more frustrating than to fail with an egg donor if you don't realize that maybe there's an underlying sperm problem on top of it?
Right. The question that I was just thinking about, is there an age where you see an increase in, say, more abnormal embryos, like after 40, after 35? Are there?
Well, put it this way, there are definitely trends and that's what it was in that bell-shaped curve, that inverted U-shaped curve, is that in any woman over 30, you're getting a higher chance every year, okay? But in some people, that whole curve might be shifted. We don't know what anyone's egg quality was starting out, because that data is collected by looking at groups of people. And for some people, they have problems with egg quality that starts in their early 20s.
Yeah, right. It could be younger, older. Yeah, there's no standard, I guess you call it.
Well, like I said, you could advise people and you could counsel them based on groups of other people. But you always have to acknowledge that this does not necessarily apply to the person sitting across the desk from you.
Right. Right. This is valuable, really valuable information.
And that's part of why it's so frustrating that 30 to 40% of people are treated under a diagnosis of unexplained infertility, when a lot of those explanations can be ascertained if you're designing your treatment appropriately.
Well, you're thorough. You go through it. I appreciate everything that you do in helping your patients and giving people
and the most important aspect of it, Lisa, is helping them make an informed decision.
Yeah.
The primary goal of a modern fertility provider should be as an educator first. Here's what your options are. Here's the advantages and disadvantages of each option. Here's the one that I think makes the most sense for you based on your family building goal. But then, letting the patient decide if they want to do an untested transfer, we can do that.
Yeah.
But you could see that when you lay it out that way, I believe that's why most of our patients actually choose to do the testing, because they realize that what might save them a little money or time up front will often cost them You know, it's like going to Las Vegas. You know, you could bet against the house, and some people will make that bet and win.
Right.
But usually it's the house that wins. And so you're not better off betting against the house for too long.
You want to bet on your baby.
Well, and that's why, you know, we are not a gambling establishment. And that's why I would rather empower people with the science and say, you know what, you could gamble and hope you get a better outcome, but the odds aren't good.
Yeah, I know. We sure were. I like to think we were like rolling the dice with our one embryo. You know, we put our faith and had that one tested. Just knowing that we had one was like.
Yeah, but again, it's one out of how many? And
out of 7. Yeah, I know, the 1 out of 7. So I like.
And as we talked about, some of those embryos had a higher grade than the one that became your daughter.
I know.
And it shows, you know, I talk about this with people all the time. That grading criteria that's most commonly used is called the Gardner's classification. We use that grading system too. It's been around for 15 years and it's never been revised.
And you know what's funny is I never knew the grades of our embryos ever like that, because you weren't my first doctor in the beginning, but that could be a whole nother topic. But I just like never even let that come into my mind. And I see so many individuals get wrapped up in the grade of it's an AB or AA, BB, whatever they are. You know, I didn't even know what ours were until you just told me. So yeah, our daughter was not as high as the other embryos that were not, quote, healthy. So it's just interesting.
Yeah, well, that's why I said the grading classification is used by most centers. And so it makes it so that we have a universal language.
Okay.
But it's also something that hasn't been revised or modernized to include genetic testing. Yeah. And then, you know, within any organization, I could tell you at our center, our embryologists keep individual notes. So if they have 2 or 3 embryos that all have the same grade, that have all actually gone through the same testing, they're still able to say, I'd recommend you use this one first, and that one is my second choice.
Okay. Yeah, there's a whole other bunch of questions we could go into about the grading.
Which is probably best for another time.
Yeah, another time. Oh my gosh, this is super
helpful. Or maybe
helpful.
Even talking to one of the embryologists, because they love to remind me I'm a clinician and I'm not an embryologist.
A clinical conversation with, an embryologist. So, oh my gosh. Thank you so much for all of this information. It's super valuable.
Absolutely. And what's most important for people that are listening, keep asking questions. And if the person's not giving you answers that are based on the latest scientific evidence, ask somebody else. You're entitled to having the accurate and current facts.
Yes. Thank you, Dr. Greene. And I know you have a blog, enhancingfertility.com, and my blog is on my website, IVF Manifesting a Miracle. So we're here for you.
And I think we're both trying to achieve the same goal, helping people make informed, well-supported choices.
Definitely. Reach out to us. All right. Thank you. Bye-bye.